All right. Good morning and good afternoon, depending on where you are. Just want to welcome innovaTel Telepsychiatry, who is a National Council Platinum Partner. And welcome to today's webinar called Telepsychiatry, a Year in Review and a Look Ahead. Before we get started, just want to go over a couple housekeeping items. Today's event is being recorded and you are in listen-only mode. Please feel free to go ahead and submit your questions throughout today's event using the Q&A function at the bottom of your screen. We will try to get to as many questions as time allows for about 15 minutes at the end of today's presentation. Keep in mind, although today's presentation is being recorded, we will have slides and the recording available on the National Council webinar archive page within 48 hours of today's event. So want to turn it over to, or just introduce quickly today's presenters. We have Jon Evans, CEO of innovaTel Telepsychiatry, and he's the Chief Clinical Officer at Quartet Health, and Shayla Nagy, Policy Director at Quartet Health. And now I'm going to turn it over to Jon. Jon?
Thank you, Amber. I really appreciate the opportunity to be here with you, and welcome everybody on the webinar. I'd like to start by really thanking National Council for not just this opportunity, but for the work they've done over the years to really, quite frankly, finally normalize the delivery of behavioral health care across the country. We literally would not be having these very productive conversations without the tremendous work they've done. And to add just a tremendous accomplishment to that, the CCBHC funding, which most of you know has come about, is literally as a result of over a decade of work by the National Council in Washington. So I think we just really need to give credit for the tremendous work they do on all of our behalf as members. So thank you very much, Amber, to you and the team. If we can go to the next slide, I'll just kind of quickly go over our agenda today. And recognize that we are going to give some opportunities for questions and answers at the end. But we're going to talk a little bit about just a review of innovaTel and who we are and what we do. Pretty much kind of some key takeaways from the past year based on our experience and research. Then fortunately, we have Shayla Nagy on with us, who's our expert in regulatory and legislative updates. We count on her significantly throughout the year to be up to speed on that. She will give us an overview of what's occurred and what we might be looking for in the year to come. And then we want to really highlight one of our true partners in care as one of our success stories, and then talk about just a couple of important considerations for the year to come. So with that, we'll go to the first slide. Just as a level set, for most of you, if you remember, innovaTel was founded in 2014, clinically owned and operated to really focus on some of the challenges that, quite frankly, we experienced in our past as a community mental health center in regards to recruitment and retention of high quality staff with the ultimate goal of timely access to care. We know, and I'm sure you know, that when an individual calls for care, any delays are not helpful. So our goal there is to continue to support that wherever we can. I'm really pleased to share with you, for those of you that don't know, that we had the opportunity to really form a true partnership with Quartet Health this past year. Quartet Health really brings some strengths to our partnership, including really a substantial tech-enabled ability to get individuals into care, as well as some very deep relationships with payers that I think will be incremental and positive towards our steps forward. So I'm really pleased to share with you that relationship. We've just finishing up our first year, and I can share with you that it's pretty much met all of our expectations and then some. So if we could go to the next slide and just keep moving, I'd like to talk about some of the key takeaways from the past year that we've found to be true. This is our experience, but also fortunately, as you can see here, has been supported by a good amount of research, primarily done by the American Psychiatric Association as well as others. But as you can see, really some positive outcomes of the ability to expand telehealth in partnership with our community partners on the ground. But the first first issue is in regards to just a reduction in the remission of suicidal ideation. As you can see, the study demonstrated that there was a significant reduction in the first 12 weeks, is what you all know is extremely important as far as timely access. There's also some encouraging research done in regards to our work with FQHCs. As you know, federally qualified health centers, along with community mental health centers, are the safety net in our country for individuals that probably are living somewhat on the edge. And so the FQHCs found that they were able to improve engagement in care, especially among Medicaid beneficiaries in their clinics. We also found that from research from the American Psychiatric Association, 85% of providers indicate that their telehealth has increased timely access to care, our fundamental goal here. In addition, 75% of telehealth allowed them, the psychiatrists, to deliver what they felt were a high quality of care, and as well as 70% felt that they were motivated to even increase their ability to provide additional telehealth care. The overall message here is that not only with our history, but I think as a result of COVID and really compelling us all to move towards a more telehealth platform, we found overall clinicians, providers of care, and most importantly, patients found that this was a very acceptable platform to get care delivered. If we could go to the next slide. So some of the lessons we learned over the past year plus is we found that part of our partnerships with our clinics is to have time allocated for medical directors, especially as it is required in a CCBHC grant. I can tell you from my past experience in a relatively rural community mental health center in northwestern Pennsylvania, where we had difficulty recruiting and retaining tenured high-quality clinicians constantly, is that we were never generally able to find someone with the experience, the skills, and the tenure to act as a medical director in our clinic, a very important role. So what we found over the past number of years is that with our ability to throw out a national net, we are able to not only recruit that level of clinician, but we're able to allocate their time in different clinics to help them fulfill that role of medical director, but not especially have to hire someone full time. So as you can see here, that many of the medical directors that we partner with our clinics are part-time. They are able to fulfill a number of roles, including just overall improvement of clinical workflow, development of policy and procedure, really have some oversight on the quality improvements and regulatory requirements, improve productivity, and of course, support the issues specific to billing, especially when it comes to Medicare. So we found that our ability to allocate hours of medical directors, usually it's in an average of about 8 hours a week in a clinic, that fulfills not only the role, but really enhances the development of a CCBHC clinic. So if we can move to the next slide. Another unique lesson learned is in regards to the allocation of forensic telepsychiatry. I think many of you know, and it's been well written, that one of the unattended outcomes of the closing of the state hospital system in this country is that many individuals with serious mental illness who are living on the edge became involved in some manner or another in the criminal justice system. There are actually some jails in the country that indicate that they may have become the new state hospital system. I believe I've read about some of the larger cities, county jails feeling that way. So we have a really robust group of forensic boarded psychiatrists headed by Dr. Keelan Garvey, who has been able to work with some of our partners to really have a positive impact. But the data indicating the need for this is pretty significant. As you can see, 56% of people in state prison have some type of indication of mental health need. Only a small fraction of them, about half, actually receive care, often not by a forensically boarded telepsychiatrist or a psychiatrist, as that matter. Telepsychiatry actually enhances our ability to get those hours out to people. We're actually working in the state of Vermont. We have a very productive relationship there with the courts, where we do all of the evaluations for court-ordered enhancement of care. We're also covering some units with forensic needs, where, again, forensically boarded psychiatrists can give the level of care that's needed, really to offer the best opportunity for patients to recover, even when they're in those environments. So we can work collaboratively with them, and we're also able to fulfill one of the requirements of CCBHCs to coordinate well with their local criminal justice systems, either as a consult or in actually to provide actual care to patients. So if we can move to the next slide, please. Telehealth also contributes to the real ability to recruit subspecialty cares. I know everybody in the webinar knows that recruitment of child and adolescent psychiatrists is a significant issue. We have a pretty good team of child psychiatrists, and we're able to meet that need. But also, as we look at the whole issue of diversity and inclusion, we were really pleased when we did a summary of our staff, that at the time we did it, which was about 6 to 8 months ago, our staff really reflected the diversity of the nation's demographics. With that said, we have a lot more we need to do. We really need to continue to recruit various diversities in regards to ethnic and race, anything specific to geriatric care, and providers that provide care to the LGBTQ community. We feel we're doing pretty good, but we need to do even more, and even in specific areas where that needs to be met. So with that said, that's a pretty broad, high-level overview of some of the lessons we continue to learn in the provision of telepsychiatry. At this point, I'm really pleased to turn it over to Shayla, who's going to do a review of regulatory and legislative updates. So Shayla.
Thanks, Jon. So building on lessons learned, we've had a flurry of regulatory activity impacting telepsychiatry over the last year. And as all entities have started to learn and look at the data of what's worked and what hasn't for telehealth during COVID and what will be working in the future, we've gained temporary and in some cases permanent flexibilities. And as we wrap up 2022 and head into the new year, we're really beginning to see what will remain in place as the dust settles and we start to return to the new normal. So I'm going to use our time today to cover what's changed, what this new normal might look like in a few key areas. I'll highlight the bright spots, and I also am going to highlight a few remaining areas where we're hoping for and advocating actively for better long-term solutions as we head into 2023. Next slide. So as we go over key changes to telehealth policy, I'm sure this is familiar to all of you, but I'll center the conversation with this general framework. When we're thinking through policy updates, we of course have to think through federal law, state law, and payer policies. And now in the era of COVID-19, we also need to layer on emergency declarations. For example, at the moment, federal law and some state laws place restrictions on remote prescribing of controlled substances. But as you know, while the federal emergency declaration is in place, the in-person visit requirements are waived and controlled substances can be prescribed virtually. Or on the payer policy front, certain provider types like licensed professional counselors are fully licensed to practice, but some payers might have different billing requirements or restrictions for these types of professionals. So we need to think about all these levels before determining whether or not something can be delivered via telehealth, and importantly, whether or not a payer will reimburse for that service. So if you go ahead to the next slide, further underlining this point, the really important thing to be looking at in this time of flux is permanent versus temporary telehealth policy. There's a patchwork of federal and state emergencies that are in place. And within that, a number of policies enabling telehealth are temporary, such as certain Medicare telehealth codes, and these will eventually expire. So what we really want to focus on, and what I'll underline as I go through my slides today, are what are the key things enabling telepractice to thrive, and will those be made permanent? Are they already going to be permanent after the end of the emergencies? And where do we still need to see a few tweaks to enable telepsychiatry and telehealth in general to thrive? And of course, as you know, as National Council members, it's not always an easy road to make these changes permanent. Some of the policy updates could be changed overnight by an agency unilaterally, but some of them, like Medicare benefits, for example, do require congressional action and can't be altered quickly. On to the next slide. The million-dollar question then is, when will the federal public health emergency end? So there's continued conversation in this realm. I think even just today, we heard some signals from the administration that they're starting to plan their contingency plans for when they wind the federal PHE down. But as a reminder, the federal public health emergency can only be renewed for 90 days at a time. This puts us into this continued guessing game of when it will be extended again versus when it's going to be truly allowed to expire. Luckily, Health and Human Services has made a commitment to giving 60 days notice before the official end of the PHE to allow everyone a little bit of time to adjust their operations. And if we go through this timeline on the slide, we're now in mid-December, and the current declaration of the PHE has it ending on January 11th. But given that the 60-day notice window that HHS would have had to give has passed in mid-November and we haven't heard anything, we're going to safely anticipate that we're going to see at least one additional 90-day extension when that January 11th date rolls around. That'll take us into mid-April. Beyond then, we're not clear, but it's not unlikely that we could continue to see some more extensions into 2023. So the key takeaway here is, again, we should know by mid-February if the PHE will be expiring in mid-April, but whether it is extended multiple times throughout 2023 or not, we think it's really important to begin operational planning, and we have here at Quartet and innovaTel to prepare for what operations will look like for a post-PHE world. On to the next slide. For enabling telepractice and some of the key regulatory updates we've seen, there's way more that I can adequately cover in a few minutes, in 20 minutes, but I'm going to focus on these key areas. One being telehealth coverage and payment, and I'll go through a few different payers. Also prescribing requirements and cross-state licensing. So you can go 2 slides ahead. We can go on to commercial reimbursement. So in the commercial realm, we saw commercial payers act really quickly to open up telehealth access, seemingly overnight when the COVID-19 emergency hit. I was tracking this for Quartet and looking at all the payers we were partnered with and just seeing day by day updated landing pages where payers realized that they needed to open us wide open to allow their patients to access telehealth from their homes. And in general, fortunately, we're seeing these payers continue to preserve expanded telehealth reimbursement. Not all payers have made their policies permanent yet, and I think that that's another key area to watch as we start to come closer to the end of the public health emergency. But interestingly, also on the state regulation front, we've seen many more states put laws into place requiring private payers to pay for telehealth services if they would pay for the same service to be delivered in person, so otherwise known as service parity. And in some cases, so you see some parity law in the books in 43 states, but in 24 states, we're also seeing state-level payment parity laws, which are requiring plans to pay providers for the same amount for delivering the service via telehealth as they would reimburse for in-person. Now, in contrast, before COVID, I think only about 10 states had such parity laws in place. So you can see here that there's been a really big growth over the course of the pandemic as the importance of telehealth has grown. And I'm highlighting this under commercial reimbursement, but note that in most cases, this also extends to Medicaid reimbursement in the state as well. Audio video is more typically covered here, but some states, including Washington, have taken parity a step further, mandating coverage of audio only, particularly for telebehavioral health. And some payers temporarily waived cost-sharing requirements, allowing members to access telehealth before even meeting their deductible. And you may have heard there's momentum in Congress right now to continue to allow those patients on high deductible health plans to get telehealth covered prior to spending down that deductible. So as always, to keep track of commercial reimbursement, you can refer to each payer's manual, and many have set up a COVID telehealth policy landing page that's providing ongoing updates as well. On to the next slide. So similar to commercial payers, we saw expanded telehealth reimbursement in Medicaid across the states. Prior to COVID, there was a wide patchwork of coverage in Medicaid. They were saying, if you've seen one Medicaid program, you've seen one Medicaid program. But now, at least on the telehealth front, we're starting to see telehealth policies converge. States have generally done away with any remaining originating site requirements that required Medicaid members to travel into a clinic site to access telehealth. So now the members in most cases can access telehealth directly from their homes. In addition to that, most states now allow both audio and video visits, as there's growing acknowledgement and evidence that audio only is really critical to expanding and preserving telehealth, particularly for vulnerable populations. I'll note that not all Medicaid programs today are allowing all services to be delivered via telehealth, but where there is coverage, telebehavioral health is one of the most commonly included services. And then, not specific to telehealth, but this last item here, after the end of the public health emergency, states are going to need to resume Medicaid eligibility redeterminations. And this might not happen for every state on day one. There's some efforts to phase that out over time. But there's a growing discussion around how to carry out these redeterminations with minimal disruption, as studies have shown that up to 15 million people are at risk of disenrollment, and that includes 7 million children. So this will be an unprecedented churn event, and you may have seen that recently, I think just yesterday, HHS released a proposed rule that would expand the open enrollment period for these people who are losing Medicaid coverage to allow them a little bit more time to enroll in market-based plans if they find that to be a good option. So this is just one of many steps that we'll need to take to promote continued coverage. So expect to see a lot more activity on that front over the coming months. So on to Medicare. Medicare has been an exciting area to watch over the course of the last few years. So as a reminder, prior to COVID, Medicare members' access to telebehavioral health care was often quite limited, and behavioral health care in general. I remember at Quartet, we were matching patients to community providers, and we were looking for therapy referral options for Medicare members in rural California. And we found many behavioral health provider deserts. So it was exciting to me to see flexibility take effect actually right before COVID, unrelated to COVID, in January 2020, that allowed Medicare Advantage plans to offer more telehealth services. This included the option for MA to allow members to access telehealth direct from their homes. But unfortunately, the Medicare fee-for-service restrictions remained in place, and those members could only access telehealth in the rarest of circumstances. They had to be in a designated rural area, and even then, they couldn't access from their homes. They had to travel into a clinic-based originating site to have an appointment with a distant provider. And a lot of these restrictions in Medicare were based on past CBO scores that estimated the cost of adding Medicare to telehealth to Medicare to be very high. But fortunately, now coming out of the pandemic, we're getting more data around the cost effectiveness and just general clinical effectiveness of telehealth. And in response to this experience with the PHE, temporary and then permanent changes were made to allow Medicare members to access telemental health in any geography, at home, and by phone. Unfortunately, though, there are still in-person requirements in statute around this that will take effect 5 months after the end of the public health emergency. And this is a key area that we're watching and planning for. At that time, unless Congress acts beforehand, Medicare fee-for-service members will need to have an in-person visit with their treating provider 6 months before initiating telehealth. There's also a 12-month in-person follow-up visit for continued treatment via telehealth, but there are allowable exceptions that can be documented in the medical record, and we believe that in many cases, innovaTel providers may meet those exceptions. One bright spot here came out in the recently released physician fee schedule. Those members who were already in treatment before the end of the PHE will be exempt from needing this in-person visit and can continue to receive telehealth care without disruption. But as you can imagine, there's a lot of advocacy going on in this area in particular to permanently remove this requirement. And fortunately, we still have a good bit of time here with the PHE plus 5 months extensions that we're seeing in Medicare. But all major associations are lobbying strongly against this and have written letters to Congress advocating for this to change. So we're cautiously optimistic that we may see some movement here before it ever goes into effect. Maybe there might be some nod to this even in the end of the year omnibus funding bill. And then one last note that Medicare updated their fees in the next fee schedule, saying that LPCs and LMFTs can practice under general supervision of physicians and non-physicians practitioners rather than direct. And this general supervision can be done remotely, which kind of expands the pool of provider types who can provide services to Medicare members. Next slide, please. So now we're turning to one of the most discussed areas in the future of telehealth, and particularly telepsychiatry, the remote prescribing of controlled substances. So during the public health emergency, there's a DEA waiver of the Ryan-Haight Act in place that temporarily allows remote prescribing of controlled substances without an initial in-person visit. In addition, to expand access to medication-assisted treatment, buprenorphine can be prescribed to new and existing patients with OUD via telephone without an initial in-person visit. Unfortunately, though, this flexibility is still set to expire at the end of the public health emergency. The DEA has been directed to create a special registration process that would allow providers to get a registration to permanently prescribe these controlled substances via telehealth. But they were directed to do this quite a long time ago and have been repeatedly slow to act on this. They did issue a notice of rulemaking in August saying that they were going to take action on the registration, which is a good sign. But those who have been following this for a while know that those deadlines to create the registration have been repeatedly missed despite repeated congressional calls on the DEA to act. Still, we do feel that we're in a moment of unprecedented attention to this issue, and we continue to see a lot of advocacy and focus in this area to ensure that teleprescribing that meets the standard of care can continue after the end of the public health emergency. And we also keep a close eye on state activity. There are state level laws in some states that restrict the virtual prescribing of controlled substances that go in hand with the Ryan-Haight Act. For example, New Jersey does not allow virtual prescribing of stimulants for ADHD for adults, but it makes an exception for patients under 19. I will say generally where these state level bills exist, they tend to make common sense exceptions to allow controlled substances to continue to be prescribed for behavioral health needs in particular. So at innovaTel and Quartet, as I mentioned before, we've been continually working on contingency plans should these regulations become fully reinforced again, but also putting energy into advocacy around progressive policies to enable continued access to telehealth as it is today. And we feel we're beginning to see some real traction. So next slide, please. We'll move on to the last main issue we're going to highlight, cross-state licensure. So as it stands today, providers must be generally licensed in the state where the patient is located before they can provide care virtually. During the earlier days of COVID, state emergency declarations in some cases allowed cross-state licensure, cross-state practice without full licensure in some states. This was a patchwork then, and difficult to navigate on and stay on top of changing regulations. But even this patchwork of narrow exceptions is winding down. As you can see in the map on the left, this is showing which states still, as of late November, had their state level emergency declarations in place. Only 11 orders remained then, and they continue to shift. So today, in general, for the most part, were returned to the state where providers really do need to be licensed in the state in which they're seeing the patient. And while some in this space advocate for maybe this is the time to end state-based licensure and think about national level licensure, we think that it's pretty unlikely that we'll see such a radical change anytime soon, as there's a strong tradition and history in this country around state-based licensing boards. However, participation in a state-by-state level in licensing compacts does continue to grow. So shown here on the right, we have the Interstate Medical Licensure Compact, and participation in that has exploded during COVID. PsyPact, Counseling Compact, et cetera. These compacts help ease the burden somewhat of cross-state licensure, reducing provider paperwork and streamlining the application process. And I think the most commonly joined this year was the Counseling Compact. So we're hoping to continue to see more compact membership, but I do want to highlight here that innovaTel ensures that all providers are fully licensed in the states they're providing services in and the states in which they're sitting prior to initiating care. So we are just making sure to cross our T's and dot our I's to make sure there's no risk of disruption in care as regulations shift. We're taking a cautious approach here. So to go to the next slide, and we can kind of sum this up, what to watch in 2023. I've already highlighted a few key areas as we've gone through the slides, including Medicare telehealth flexibilities and those virtual prescribing requirements for controlled substances. But beyond these, I think that 2023 is going to be an exciting year for mental health policy. We're working in a rare area of bipartisan agreement when we're in the mental health space. It's getting a lot of focus on the federal and state levels, including from the Senate Finance Committee that's released a series of discussion drafts that outline really exciting mental health priorities. Things like supporting behavioral health integration in primary care, bolstering network adequacy requirements, and really achieving full-on mental health parity enforcement. So we're seeing these priorities incorporated into bills that we're going to be watching closely over the next few months. And in addition, we anticipate continuing to see all payers, commercial, Medicare, and Medicaid, learn from the wealth of telehealth data that's now available and adjust their policies to preserve members' access to this high-quality, cost-effective telepsychiatry care. So with that, I'll pass the mic back to Jon to review some success stories from CCBHCs who've grown their telehealth services with innovaTel.
Thank you, Shayla. And, as I'm sure you all can tell, Shayla's just a wealth of information. We count on her every week to keep us updated, to make sure that we're delivering care in accordance with all the legislative and regulatory requirements. I would agree it's been generally a positive year in regards to trending of some of the more outdated regulations to allow us to do our work, but more work to be done. I would also add that the National Council on all of our behalf does a significant amount of advocacy on the Hill to help move some of these regulatory issues along. So with that, if we can go to the next slide, I wanted to talk about a success story that we've had over time with just one of our tremendous community mental health centers. As I mentioned earlier, our goal is to partner with the community providers to ensure and enhance their staff to make sure they have adequate coverage for the demands at the front door. I think it goes without saying that the demand has been unprecedented. I would suggest both due to COVID and again, the work that National Council's done to allow the discussion about behavioral health care to become normalized in our conversation at a national level. So I'd like to talk about High Plains Mental Health Center in Hays, Kansas, which is a very rural mental health center. If you can imagine, covers 20 counties and has a population of over 100,000, but there's only about 5 people per square mile, which I understand in federal regulation is not only considered rural, but frontier under the classification. So really, if you can imagine individuals who are that isolated geographically, when they need behavioral health care, getting into a clinic can be a bit of a burden, both from a time and a cost perspective. High Plains has done a miraculous job in making sure that that area is covered. I want to give full credit to Walt Hill who is the CEO and our partner there. Probably many of you know Walt. Even though he lives in, as you can see, a very rural environment, he has been one of the more progressive CEOs that we've worked with, really wanting to ensure that there is a robust level of mental health care provided there. So as you can imagine, living in Hays, Kansas, they had some challenges with recruiting and retaining high quality psychiatrists who, if you can think about it, can live anywhere in the country, and probably unless they maybe grew up in rural Kansas, were not so inclined to move there. So if we could go to the next slide. As you would expect, as CEO, Walt was very rigorous in regards to a partnership with us. So we started talking to him actually in 2018 about, the opportunity to partner and care with him. He needed additional physicians, but he stuck his toe in the water, so to speak, with one part-time psychiatrist. Now in 2022, the relationship is tremendous. We're really honored to be able to be a partner. We now have 7 psychiatric providers there, 10 therapists, and we just recently launched a MAT level of care program. I can say that Walt and his staff have been tremendous partners. They've welcomed us as providers in care, and we really view the clinicians that are with us and them as a virtual member of their team. They attend treatment meetings, really work closely with the staff, and pretty much are there in the clinic every day. If we could go to the next slide. So High Plains is a certified community behavioral health clinic. They're working very diligently on the initial grant to make sure that they meet all the requirements. It's, in support of that, as you can see, as a result of our relationship with them and our ability to enhance the bandwidth of clinical staff, they've really been able to improve access to care. So as you can see, it's gone from 2 weeks to 3 days for the initial assessment when an individual calls. And then after that, from 6 weeks to 2 weeks to get access to a psychiatrist. Significant difference in the implementation of care, which, as we all know, if you track outcomes, the less time one waits for care, the outcomes improve overall significantly. Next slide, please. Walt's team has, I'll just kind of give an overview of this, has provided us with an overview from data from their clinic in regards to both telehealth, both offered in the brick and mortar clinic as well as at home. I think we all experienced a very quick pivot, as everybody did 2 years ago when COVID hit with full force, that we had to work very closely with our clinics to provide care in the home, as some of the clinics had to really go through quarantine protocols. It's fortunate that I think our patients have taught us that this is a very acceptable level of care, both in the home and in the clinic. And I believe that this data demonstrates to us that really going forward, a hybrid solution to the delivery of care is what's really going to help us meet the needs and the high demands for behavioral health care. Next slide, please. So again, I think we mentioned this, but the ability to really provide care to very disparate populations. When I talk with Walt, he talks frequently about the aging population in regards to family farms and the isolation that they have. If you can imagine the work that they do in the agricultural community to keep their family farms running, there's significant pressure. Everything has to go almost perfectly from cost of feed to cost of agriculture to the weather to make sure that they have a good season. Significant pressure. So having access to supportive behavioral health care when it's necessary is critical. There's also a significant Hispanic population who tend to find sustainable work in those communities, and we're able to provide bilingual clinicians as well. So we found that in a very rural area, such as Hays, Kansas, and High Plains Mental Health, this has been very helpful. Next slide, please. So we've been able to increase services, as we mentioned, as a result of our partnership. Specifically, we're really proud that we were able to, in partnership with the High Plains team, is to launch a MAT program. There was a significant need in regards to addictions care in that very rural area. We're pleased that we have staff that have the capacity to do that. I'm sure you're all aware that one of the highest needs for recruitment in the past couple of years was LCSWs to add to the therapy team. We share in that demand at the front door, and we found that recruiting LCSWs to our team has been a major focus. With that, though, we were able to partner with the High Plains team to not only recruit LCSWs to ensure that they were licensed in the state and be able to add to treatment. I think also significant is we were able to partner with Walt's team to initiate an assertive community treatment team, which, as we all know, it is fundamental to successful care with individuals with serious mental illness. So overall, a real true partnership and care, hand in glove every day with their team. We do have a clinical operations team that works very closely with all of our partners in care to ensure that everything's going smoothly every day. So if we could go to the next two slides, we're just going to take a quick look ahead as to what we perceive as probably going to be some of the key components of the continuing delivery of telepsychiatry going into the new year. I think we all want to capitalize, quite frankly, not just in regards to telehealth, but in regards to the delivery of mental health care, to the increased acceptance of mental health care in this country. I'm sure you've all seen it, but when we now see ads on TV and in major publications and just general conversations across the board, I'm tenured enough in the field to know that this was not true some years ago, that mental health care was still in the shadows, still a significant amount of stigma attached to it. I feel pretty confident in saying that the issue of stigma has, for the most part, been reduced over the past 2 years. We still have work to do, but I'm just really pleased about the positive conversation that mental health care is fundamental to overall whole person care. Next slide, please. We're also really pleased, as I mentioned at the outset, of the increased funding through the CCBHC system. When I was CEO of a community mental health center in Northwest Pennsylvania, we had similar challenges to those that I mentioned at High Plains that Walt is challenged with. The increased CCBHC funding is finally a sustainable platform for funding of community mental health centers. I can tell you in my tenure of over 20 years at Safe Harbor Behavioral Health, we literally lost money on every hour of psychiatric care we provided, and we had to do a number of things to backfill those expenses. The CCBHC system really fully implemented has proven to solve that. So once again, can't thank the National Council team enough for their continued advocacy over time to make sure this funding has increased. I think we all should join them in continued advocacy that this funding remains in place in perpetuity. Next slide. So the evolution and the continuation of what we've learned is what I would describe as the hybrid model. I really do think we've learned that telepsychiatry and telebehavioral health is an accepted modality, but clearly we've also learned that some of the more traditional services in the community are critical. I see us as an add-on to the traditional services provided. We could not do our work without our partners, specifically in regards to the clinicians that are front lines on the ground, case management teams, peers, everything, all the robust services the community mental health centers provide are critical to all of our success, and would strongly advocate that they remain in place. Next slide, please. So, as Shayla mentioned quite diligently, navigating the complexities of state licensure is a challenge. It is probably our most significant delay in going live with care. So I can tell you right at this point, we have a large number of contracts that have been signed with us, a significant amount of detail in regards to putting together a partnership with our clinics to ensure that we have, hold on here, I lost my site here. So there we go. To continue to ensure that we have clinicians in place, but it can take sometimes between anywhere from 2 to 6 months to get a license from a clinician that's already duly licensed in another state. We are continuing to advocate for a smoother path there. We are respectful of state licensing boards. We understand they have a job to do, but would like to encourage them and ask for your joining us with advocating for a more, I think, expedient system to get a license. Next slide. So increased focus on advocacy overall. Again, National Council has done some tremendous jobs. We have been working also in partnership with other associations, the American Psychiatric Association, the Child and Adolescent Psychiatry Group, the American Telemedicine Association, all are working towards improving the regulatory and legislative area to ensure that we can move quickly to develop a broad network of care for timely access whenever and wherever it's needed. So we would encourage you to continue to be active members of the National Council, as well as support any of the legislative efforts that they put forward. I know many of you probably receive alerts from Chuck regarding please support this effort, and I would really want to encourage you to do so. Next. Okay, well, that is pretty much the end of our presentation. We would like to spend some time with questions and answers. So I think, Amber, if you're going to kind of manage any questions that have come in, we'd be happy to do our best to answer them.
Absolutely, and thank you guys. And if you have any questions, please go ahead and submit those at the Q&A function at the bottom of your screens. It looks like we have had a couple come through already. One of the first questions is, someone wanted you to confirm, and I think this is for Shayla, that Medicare will end telephone audio only after the PHE.
Yeah, so great question. Actually, Medicare will continue to reimburse for audio only, specifically for mental health and substance use disorder after the end of the PHE. So that's a permanent change that they made, I think, about a year ago in one of their final rules. So fortunately, that will continue, but only for mental health.
Okay, great. This next question. For Medicare, will Medicare LPC or LMFTs MPI need to be credentialed, or will they bill under the supervising doctor?
Yes, so I might need to follow up to confirm some of the details around this question. However, the change is that they will be billing under the supervising provider. It could be a physician or a non-physician practitioner, like a PA or NP. They will be doing incident to billing, and the change that Medicare made in the fee schedule specifically moves them from requiring direct supervision, which after the end of the public health emergency will require that supervisor to be actually on site with the provider, to general, which can be done virtually. What I have to double check on is this question about credentialing. I believe that the provider will still need to be credentialed with Medicare, but can confirm that and get back to you.
Okay. The next question that we have, in your experience, is integration of the biopsychosocial model for the care of individuals with chronic pain part of telehealth psychiatric services?
Oh gosh, that is a good question. I mean, obviously anybody that is experiencing a medical condition with chronic pain is going to have, some emotional overlay. My experience, at least at the community mental health center that I was active is that was not one of the primary clinical presentations we dealt with, and traditionally was managed through a pain management clinic. That does not go without saying that wouldn't be a good partnership to combine work with a pain management clinic and have some behavioral health clinicians partnering with them. But that's, in my experience, that wasn't generally a presenting problem at a community mental health center. I would just add the caution there is probably also in regards to, as Shayla outlined in her presentation, we're going to be hopeful that there'll finally be movement with the DEA and thoughtful ability to prescribe Schedule II medications within clearly a rigorous standard of care. Generally, again, my experience at community mental health centers, pain management is not something that was within our clinical purview.
Okay. Thanks, Jon. I just want to mention we do have a question about the slides being available. Today's presentation and slides will be available on the National Council webinar archive within 48 hours. So yes, it will be available soon. This next question is a clarifying question about innovaTel services provided, and if innovaTel provides services in schools, and why or why not.
I believe we do have a few small clinics. There would be no reason that we could not. I know many community mental health centers, again, including the one that I have experience with, had satellited their outpatient therapy modality into the schools for children. It's a very productive way to offer care. So their limitation in attending classes is mitigated. So we of course could do that with the proper connectivity and security. There's no reason so that we couldn't provide that in a school in concert with a community mental health center.
Right. Let me just check. And if you guys have any additional questions, we have a little bit more time. Please feel free to submit those questions. Let me just double check here. We did have a question that came in through Dylan, but I think this is going to be a follow-up that Shayla may want to answer individual. Just want to put that out there that we do see your question, but we'll follow up separately with that one. We don't have any questions coming through just yet, but Jon, is there anything else that you want to add that will kind of just be helpful to just wrap this up a bit before we get off?
Sure. Listen, really in a positive vein, I'd really, again, like to reinforce how really rewarding it is to have a robust national conversation about the provision of mental health care. I really do think it's become normalized, not just through National Council, which has been the leader, but through a number of other organizations, including now, finally, I think most of the major payers of healthcare have recognized that they need to have a fairly significant behavioral health capability to really have a good overall health program, as well as reduce their costs, because we know in our field that when behavioral health is readily available, overall healthcare costs also go down. And with that, I'd also just once again like to thank National Council for this opportunity, and really wish everybody just a very happy holiday season coming up.
All right, thanks so much. And just a reminder that today's presentation will be available on the National Council webinar archive page. If you have any additional questions, please feel free to send us an email at communications@thenationalcouncil.org. And thanks once again, everyone. Have a great day.